Hello everyone, I am Dr. Elavenil, a professor in the Department of Oral and Maxillofacial Surgery at SRM Dental College, Chennai. And this presentation is about Zygomatico maxillary complex fractures. When I was a student like you all, I used to wonder why this was called a complex, in contrast to all other fractures which are named after the bone, like for example condyle fracture, frontal bone fracture or nasal bone fracture. I'm sure even you all must be wondering why this is being called a zygomatico maxillary complex fracture rather than a zygoma fracture. And the reason is this. Zygomatico maxillary complex is considered as an anatomic unit formed by zygoma and maxilla because structurally and functionally they influence each other. And if you notice carefully, zygoma is articulating or it is in close connection with the maxilla by a long suture. This is the suture. So any impact to the zygoma generally affects the maxilla and vice versa. Another important aspect was discovered a little later. Zygoma was found to be intimately related to the orbit also. Any change in the position of the zygoma affected the eye also. So today, zygomatico maxillary complex is also called zygomatico orbital complex. So the bottom line is zygoma is connected to the maxilla and the orbit. Through this presentation, I will discuss the components of the ZMC complex, classification of ZMC fractures, clinical features, radiological assessment, decision making and treatment, the reduction and fixation methods, as well as the complications. First of all, one needs to understand a few terms which are specific to zygoma. It is important to be familiar with them to understand the clinical features and treatment better. Remember, zygoma has 5 processes. To start with, the frontozygomatic process which articulates with the frontal bone. And this is the frontozygomatic suture shown in red. The zygomatico maxillary process. The zygomatico maxillary suture shown in red. The infraorbital process. The zygomatico temporal process. The red line showing the zygomatico temporal suture. And lastly, the zygomatico sphenoid process with the red line showing zygomatico sphenoid suture. Here we have all the 5 processes shown. So remember, zygoma has 5 processes. Because of the numerous processes, ZMC fracture is known by different names. If there is separation at 3 points, the frontozygomatic, zygomatico maxillary and infraorbital, we call it as tripod fracture. When a 4th point is involved, the zygomatico temporal, we name it as tetrapod. And finally, when all 5 points are involved, we call it as pentapod fracture. Before I move on to the clinical aspects, I want to introduce a few soft tissue structures which will make you understand the clinical features better. Remember, 2 muscles are attached to ZMC, masseter and temporalis, both of which are jaw closing muscles. Then you have the maxillary sinus closely related to the zygoma and the infraorbital nerve coming out of the infraorbital foramen which supplies the lower eyelid, lateral wall of the nose and the upper lip. Then you have the suspensory ligament of Lockwood, which is a ligament which supports the eyeball or the globe in the orbit. It extends from medial to lateral orbit like a hammock and gets attached to a bony projection called the Wittnall's tubercle, which is present below the frontozygomatic suture. Any change in the position of the ligament can change the globe position. Now, let's take a look at the classification of ZMC fractures. The first was proposed by Knight and North in 1961, according to which Group 1 represented undisplaced fractures, Group 2 isolated displaced type, Group 3 where whole body is displaced but not rotated, Group 4 medially rotated, Group 5 laterally rotated, and Group 6 with multiple fracture lines. The next classification is what was proposed by Rowe and Williams in 1985, and this was based on the stability presented by the zygoma after elevation. So you have two groups, fractures which are stable after elevation and fractures which are not stable after elevation. Fractures which remain stable after elevation would include arch-only fractures and those which are rotated around a vertical axis, medially or laterally. And those which are not stable after elevation would include arch-only fractures which are inferiorly displaced, those which are rotated around a horizontal axis, medially or laterally, those fractures which were dislocated en bloc, and finally the comminuted fractures. The next classification of importance was proposed by Rodrigo in 2013. A1 referred to fractures which were isolated zygomatic arch fractures. A2 lateral orbital wall fractures. A3 infraorbital rim fractures. B represented complete monofragment with disarticulation at all sutures, and type C referred to multifragmented fractures. Moving on to the clinical assessment, remember to examine ZMC fractures in the same sequence as any other fracture. You start with inspection, move on to palpation, perform the functional examination, and then move on to imaging. Starting with inspection, zygoma is also called cheekbone. So it is very important in determining the facial symmetry, the width as well as the projection. So a fracture of the ZMC causes flattening of the malar prominence as well as the arch, as what you can see in all these pictures. The next set of symptoms are related to the eye because, like I mentioned before,